Well, thank you for inviting me. Okay, so what we're going to talk about is the burden and impact of HPV-related head and neck cancers. Disclaimer, no financial conflict of interest. So the first thing we have to think about is, what do we mean when we say the burden? And it's interesting, you know, this is the start of a paper that includes two of the best-known health economics cancer researchers in the United States, and someone who sits just around the corner from where I sat when I was in the School of Public Health at Johns Hopkins. And so when we think about burden, the first thing we have to think about is the fact that normally the easiest thing to think about is dollars, economic burden, cost of illness. And you know, there we start with just what does it cost to provide the care. But that's not all we're interested in most times. We're also interested in the social burden. What's the loss to society? So we can think about years of life lost. We can think about lost productivity of workers. We can think about lost quality of life for the individual patient as well as for their family. And then in terms of physical measures of the burden, we could think about health-related quality of life. We summarize that in measures that we see. If we read the literature, particularly on economic burden, we see quality-adjusted life years. And in much international work, we see disability-adjusted life years, which are sort of two sides of the same coin. But the key is we're trying to get some estimate of the amount of disability or quality of life impact relative to other diseases where we have some boundaries, you know, with one boundary being the person is in perfect health and the other boundary being that the person is dead. So where does economics fit in? Economics fits in several ways. We have these cost estimates, and we're interested in cost estimates for a couple of reasons. First of all, we have to know how much to budget for care for these types of diseases. And we have to be able to anticipate how much we're going to spend, and that could be at the individual hospital level, it could be at a sub-national level, or it could be at a national health system level. We also have to think about cost effectiveness, and sometimes we like to use cost effectiveness to help to allocate resources. Even though I am a health economist and a little biased towards using cost effectiveness, of course, I often like to remind people it's never the only thing that we should use when we allocate resources. We have to think about politics, we have to think about ethics, but certainly thinking about how many euros or how many dollars we're spending and what we're getting for that expenditure in terms of quality of life and length of life is very important. We can also try to assess the impact of investments in research. And you know, if we're going to do more research on how to treat a disease or do more research on how to prevent a disease, then it's nice to have some understanding of what the return on that investment is. And one way of measuring the return on investment is to be able to say, here's how much we're saving because people don't get this disease or don't progress any further than a given level. Okay? And so understanding the cost of the condition is useful for making an economic argument about efforts to reduce the burden of the condition, but usually to complete that argument, we need to know something about how costs change when we implement a care or a prevention plan. So when we think about economic burden, we can get different international perspectives on this. So one study from France, and you can see the data here talking about nearly 240 million euros, and you can see it divided up, whether it's care, whether it's the amount of euros attributable to men and women, to different types of cancer, head and neck cancer specifically by male and female, and you can see how this gets divided up. And this is also interesting for thinking about policy issues because it can guide our thinking about what will be the distributional consequences and what will be the impact on different subsets of the population as well as the population as a whole. We will often see in the literature what are called cost of illness studies. Cost of illness studies are trying to quantify the economic impact of a disease, and we use them in combination with information about the incidence and prevalence, morbidity and mortality to describe how a disease affects the population. And we see cost of illness used in two different ways. The more technical economic definition is that we want to know how much it will cost for someone who gets the disease for the rest of their lives. We also use cost of illness to talk about how much it's cost to treat everyone in the population with a condition at this point in time. So using some of the data from this morning on the number of cases in Ireland, if we have 600 new cases a year, then we're interested in how much those people are going to be spending over the rest of their lives. That's one interpretation of the cost of illness. The other is if you've got 4,000 people over Ireland who have the condition overall, then you could ask how much does the economy spend on that population? Two different questions. One is a per year question, one is a rest of their lives question. The easiest thing to wrap our brains around are these direct costs, medical care expenditures. And in some systems, it's easy to measure medical care expenditures because we pay on a fee-for-service basis. In other systems where you have a national health system and budgets, sometimes we have to think about how we're going to measure those expenditures. But that's the easiest thing by far. The productivity losses are a challenge to measure. We have to think about whether we're going to try to actually look at what the individual patients do and use the patient's own socioeconomic status and own earnings capacity to measure the indirect costs, or are we going to use sort of the average? So for the example of the first case from the last roundtable discussion, if we have a 34-year-old female, are we going to use sort of the average wage for 34-year-old females, or are we going to ask what that particular 34-year-old female is doing? Is she a lawyer? Is she an administrative assistant? Is she a physician? Very different levels of productivity loss if we go to her individual wage. And when we think about productivity losses, again, it's really important to remember that it's not just the patient, it's the family as well. And then we have intangible costs, things that are even more difficult to value than trying to value lost productivity, but trying to value in a monetary sense what the value of lost quality of life and lost length of life is. But all of these can be part of a cost of illness study. Here's some interesting data looking at yearly incidence counts of HPV-associated cancers in the United States. And again, this would be part of characterizing the burden overall alongside our data on cost of illness. Here's some additional data that we could use to describe the cost, to describe the burden. This is looking at males, estimated new cancer cases, and deaths for oral cavity and pharynx in the United States. Again, just to give some perspective on if we're trying to give an overall picture of the burden and not simply talk about what we might think of as the most narrow economic definition in monetary terms only, what extra data would we have to provide? It's been referred to as an epidemic, so we might think about, what is the actual incidence and why are we thinking of it as an epidemic? And again, there's been plenty of epidemiologic data presented earlier in the day to convince us that this is something that is demanding of our attention. Additional data, again, to talk about what the overall burden would be, just for illustrative purposes. There's a whole bunch of different data on here, but to get closer to the economics, which is where I can add something that wasn't already discussed, I won't dwell on this slide too much. And again, this is survival. The interesting thing about survival, of course, is that we see the difference in survival between low risk and high risk. One of the characteristics of low risk, intermediate risk, and high risk in this particular slide is whether or not the case is HPV positive, and you can see the other characteristics that determine whether they are low, intermediate, or high risk. And so one fundamental question that an economist would like to be able to answer and add to the discussion is not only are these different for epidemiological purposes, not only are they different for clinical management purposes, but are they truly different in economic terms? Does it cost us different amounts to treat these different types of cases? And would that then have an impact on the cost effectiveness that we try to talk about for different care management procedures for these patients? So here's some additional data on morbidity. And when we think about morbidity, this feeds into quality of life data. And you can look at quality of life over time, measured in some ways simply as whether the person characterizes themselves in outstanding to very poor health. And you can look at this over time. This is one measure of health. Again, in the health economics literature, particularly when we talk about quality adjusted life years, we're trying to move beyond simple responses to ordered scales and actually trying to say, on a scale of 0 to 1, where 1 is perfect health and 0 is death, where would we rank a person? And when they have problems with things like swallowing, speech, changes in diet, and depression and the other issues that are listed there, there might be any number of ways in which their quality of life is impacted. So cost of illness studies, again, we're looking at these data to sort of come back to thinking about what we've seen, and we've seen some pieces of all of those data up to this point in time. Another important thing to think about, though, is what is the methodology that we're using for cost of illness calculations? And one reason that we worry about this is that if we look at the history of cost of illness studies in almost any area in healthcare, and cancer and mental health are two of the areas in healthcare where there's been lots of cost of illness studies compared to other areas within healthcare and public health. We find that not everybody follows the same rules for doing studies. So when you're doing a statistical analysis, there's a right way of doing a t-test, and there's a wrong way of doing a t-test, but everybody knows what the right way is. We're all trained in how to do a t-test or how to do a multivariable linear regression in a statistics course at some point in time. Okay? In cost of illness studies, there hasn't been any absolute right and wrong defined in the same way that we have absolute rights and wrongs sometimes defined in statistics. Now, my statistics colleagues tell me there are even nuances in statistics, of course. But the key is there's been a variety of efforts to come up with consensus on best practice when it comes to economic methodology, but we don't have this sort of absolute best way of doing things. And so what we find is that the methods that have been used are actually quite inconsistent. What's included, what's not included. How do we calculate something? 5 different ways of calculating the same thing, even when it is included, makes it very hard to make reasonable comparisons across studies. Okay? And some of the difficulties that we have are with reliability, where it can be difficult to identify the costs specifically due to a particular illness, particularly in the case of, again, one of the cases that we saw in the last roundtable discussion, where you have comorbid conditions in addition to the cancer. And then consistency, are we adjusting for comorbidities and disease? And then relevance, how is it being used in the resource allocation process? And even the existence of cost of illness studies is debated among health economists. Some health economists say, well, we should never do a study unless we're actually talking about how the cost of illness changes when we suggest a new treatment protocol or a new treatment methodology. And the arguments for, though, is that we can talk about the total cost of a disease to an economy or to a society, and that helps to get the public's attention. Although I always like to say we get into this argument of my disease is bigger than your disease. The cancer specialists like to say, well, cancer is costing this much. And the heart disease specialists like to say, well, COPD and heart attack is costing this much. And the depression and mental health specialists like to tell us how much their disease is costing. And everybody likes to claim that their disease costs the most. But it does help to get the public's attention, and it can at least begin to inform planning about how important and how much of a difference could be made if we were able to make a substantial impact on the disease. The arguments against is that it really doesn't aid decision makers unless we know how the cost of illness changes when we change our treatment protocol. There aren't, in fact, standard guidelines, which I had made some allusions to earlier, and the reliability and consistency issues that were mentioned on the last slide. So there are some scientific difficulties, there are some decisional difficulties, and yet it is a useful measure for being able to just grab people's attention and say, this is costing us millions of euros or billions of dollars or whatever the amount is for a particular disease in a particular country. It's also important to remember that the perspective matters quite a bit. We'll often read about trying to use the societal perspective to help inform decision making, and that's all of the costs for anyone in society. But despite the scientific interest in the societal perspective, and at least if everybody used the societal perspective and tried to include all costs, then we'd be playing by closer to the same rules from one study to the next. I haven't found too many decision makers who actually care to use the societal perspective to help make their decisions. Decision makers are usually coming from their own perspective. They are working in a national health system, so they're interested in the healthcare system perspective. In the United States, we might have a private third-party payer, so they just want to know how much it's going to cost them. The government might be interested in how much it costs to them, and of course, all of this isn't relevant at all unless it works out for the participants, the patients, and their families, as opposed to the physicians or the healthcare system, because the patients and their families ultimately have to bear at least some of the cost, even if they are only the indirect and intangible costs. And patients and their families may not be compliant or adherent if the economic decision doesn't make sense for them. So this is simply an illustrative table to remind us that depending on which perspective we're using, we might include much different costs, and we might come up with much different answers as to how much of a burden a particular disease is. There are at least 4 different methods just for the direct cost estimation. As I mentioned, there's these direct costs as well as the indirect costs, and it's notable that we don't even have a single method for calculating the medical care costs. And so here's 4 methods. One is looking at all of the care costs. So we could, for our head and neck cancer patients, we could say, what are all the costs of their care? Now, your first reaction might be, well, not all of their care is going to be due to their head and neck cancer necessarily. And so that's a shortcoming of that particular method, but it gives us a starting point. Because the first thing we have to do is at least know what are the aggregate amounts that they're spending. Then we could try to say, what are the diagnosis-specific costs? Okay? And so there you need some type of claims data or other system that tells you here's what this care was for, and then we can just add up all of the care that's linked to that. Again, in most claims-based system, one problem with that method is that, oftentimes when the coding is done for claims, people will put down all of the conditions that a person has, not necessarily a specific condition, although there's often primary and secondary. But then you get into all these questions. What do we count? Is it just primary diagnoses? Is it secondary diagnoses? So even there, some interesting characteristics. We can also use a matched control method. So this type of method is actually very similar to how we might arrange an epidemiologic study, and simply say, we're going to try to find in some database are patients with a given disease, and we're going to try to match up a group of other individuals who don't have the disease, who match on some other pre-specified characteristics, and then simply look at the difference in cost between those 2 groups. And finally, if we have a large data set, it could be survey data or it could be claims data, but if we have a large data set with many personal characteristics for the individuals, including their disease status and perhaps some other measure of overall comorbidity burden, we can then try to look at a regression model and control for age differences, sex differences, rather than matching on them, and then do the estimation that way. So 4 very different methods, okay? And you can see the number of articles for each of these. The most popular is to try to just use the sum of all of the diagnosis-specific costs, but the other methods have also been used a fair number of times. Each method has its pros and cons. Some of them are simpler than others. Some of them require more data than others. And overall, there is no single best method. I think that the total medical expenditures probably has the most shortcomings, but it is also the easiest by far compared to the other methods. So what's interesting is what happens if we actually try to use all 4 of these methods and look at data from a large national data set in the United States. And while I'm presenting this, most of the actual work on this particular table was done by Dermot when he was in the US. Spent many, many hours trying to sort out how to actually get these data to behave in a way that we can analyze them. And what you see is that it's interesting. So this is a data set that contains 10,000 or more observations per year, and yet over a 6-year period we could find only a very small number of cases that fit into the characteristics that we needed. You can see it's 105 for one of the samples and 111 for the other 3 samples for analysis. And what's interesting is that we're looking at the per person per year mean costs. The averages range from $14,700 US per year for the all medical care expenditures to just under $7,000 per year for disease-specific medical care expenditures, to just over $7,000 per year when we match, and then as little as $5,000 per person per year in the regression-based approach. So what is the takeaway message from all that? And then, of course, we can try to apply that to the prevalence of the condition in the United States to get an overall U.S. burden per year estimate, which ranges on this table from as high as $3.1 billion US down to just over $1 billion US per year. So no matter how you look at it, I should say that the amount is not a small amount. I mean, $5,000 for one condition per year is as much as about the average medical expenditures across the United States for everybody on a per year basis. But the key is there's almost a threefold difference between the minimum and the maximum, And even if we take out the all medical care expenditures, there's about a 1.4 ratio between the highest expenditures and the lowest. And so the method really does matter. And when we think about how to talk about the burden of disease for a particular disease in a country, paying attention to the method that we are using if we're doing the estimation, or paying attention to the method that the researchers use whenever somebody else is doing the estimation is quite important, because it will help to help to sort of frame our understanding of what the burden of disease is. The morbidity costs are also substantial. This is mean complication-related costs in out of 6 months total healthcare expenditures for treatment. And you can see that these are quite large depending on which type of treatment is being used. Indirect costs for productivity issues, you can see here that we're looking at human capital cost in terms of lost amounts of productivity over a lifetime per person on the order of 100,000 to 200,000 euros per person. And friction cost is a term, again, that economists use not for the own individual's inability to work or to work at the same level they may have used to work, but friction costs are about hiring a new person, advertising, the time the job goes unfilled. That's what that cost is measuring, and even that is not a small amount on a per person basis. Now in the US, we did find 7 studies of the economic impact of human HPV-associated head and neck cancers. And the studies included aspects of the overall economic burden, and 5 studies were related to the cost of treating head and neck cancer. And this is just a summary table. Once again, the key takeaway message here, because these numbers are very small for trying to read from the audience, but the key takeaway message is that there was quite a bit of variation in the numbers that the studies came up with. And it's important to think about what year the study came from, what methodology they used, what data they used, how they performed the cost estimates, and then what perspective they were using as well. From the National Cancer Institute, a variety of data, and they have indicated that the HPV-associated oropharyngeal cancers impose a significant economic problem. Their estimate came from the number of cases and a $33,000 per case estimate. And if you look at other estimates, you can come up with as many as 10,000 cases per year and as much as $85,000 per case. So an estimate much closer to $1 billion rather than $151 million. The cost of illness for HPV head and neck cancer, and again, this is just summarizing some data, looking at the direct medical costs, looking at the cost per case, looking at indirect costs, and how we could summarize all of these. So in trying to take what we talked about at the beginning about how to characterize economic burden and put it in some terminology that we have using the US data, this is the way that it can be approached. You can also compare future health metrics and thinking about where this is going to go in the future, particularly comparing HPV positive and HPV negative head and neck cancer. And you'd want to compare to talk about how the burden will change: incidence rates, prevalence, years of life lost, mortality, disability or quality adjusted life years, and years of working age lost. And again, there are some things that suggest we might have higher burden associated with HPV negative. There are others that would suggest that we would have a higher burden from HPV positive. This is just a comparison of the cancer burden and the research spending, and just looking at where the burden versus spending fall for different types of cancers. And the main takeaway message is to show that the oral cancer, and just picking oral out as one here, which is circled in red, is a rather small fraction of NCI funding in the United States, whereas the burden is a bit higher. And then how do we take this to a policy question, taking the burden information to a policy question? One way you could use this is to address the issue of HPV vaccination in boys in the United States, looking at the cost per case, looking at the survival, and looking at the amount that's attributable to HPV 16 and 18 in particular. And again, this just shows that there are 2 studies by the same group, and even by the same group, you're getting different costs per case and different percentages of attributable disease. And then looking at the HPV vaccination rates of girls and thinking about how the vaccination rates for boys, if that policy were to be adopted, would compare and fit in with the HPV vaccination rates for girls. That's an interesting, again, policy question, a way to bring the economic burden data into the discussion. The cost of vaccination is an important thing to think about, because we've been talking about the cost of the disease itself. The cost of vaccination, at least for the vaccinations that are out there, is not a small amount in the United States when the burden falls on the families of the children who we are thinking should be vaccinated. And that's a policy challenge, just the way that the care and the pricing structure is organized in the United States. So, in conclusion, direct cost, looking at medical care expenditures of HPV head and neck cancer in the U.S., estimated, starting point of 151 million. That's probably an underestimate. And again, one key to think about is that the method of the estimation makes a very important difference. Human capital productivity losses in the United States are about 3.1 billion. And that tells us that HPV-related head and neck cancer is like many other conditions, where if all we look at is the medical care expenditures, we're actually getting just a fraction of the total economic burden on the country. And in this case, the productivity losses are due to a number of reasons, but we can even ask, is it due to early mortality? Is it due to the inability to work at all? Is it due to the need to take extra days off? Or is it due to the fact that the person can work, but they're not as productive as they might be? And all four of those are important to consider. And so the final conclusion is that we are really, in the US and elsewhere around the world, in urgent need of better cost of care estimates for HPV head and neck cancer. And that will inform cost effectiveness not only of new treatment methodologies that we might consider, but it will also inform cost effectiveness of vaccination. Thank you.